Maybe I'll ask participants to go to the microphones if you like, and I'll kick us off, if I may, with some thoughts, and really, I think, inspired in part by the terrific presentations this morning. I think that the challenge I see is that Fiona, you did a terrific job of outlining, what the solutions might be, but it's a matter of scale from my perspective. It's a big country out there, and there's lots and lots and lots of practices that aren't anywhere close to the level of expertise that you're trying to impart into your trainees, or you do impart in your trainees. And so I struggle with, how do we scale that level of expertise across the thousands of practices that are operating at a very different level? And so my question is it possible to consider, through peer learning and other adult educational programs that we've been discussing, is it possible to, for lack of a better word, deputize oncologic imagers that are already in practice? And and maybe I'll clarify a bit further what I mean by that is that not uncommonly I'm asked to consider practices that might be in the range of, say, 20 or 30 practitioners, and a radiologist, say, or pathologist potentially. They don't have the scale even to practice at a subspecialized level. Never mind oncology. They may have all subspecialty training, but they don't have the scale to actually use it. So today they may have an MSK person and an abdomen person reading the MRs, and there's no neuro person. And so they may try and find the neuro person to read the really tough case, but they can't even get to that point. And so I start wondering, should they, either they have to merge with other groups to actually give them the scale, or can they in fact try and elevate their game across their practice by sort of deputizing certain individuals they may be primarily trained in neuro, but do they have a deputy focus? Are they deputized for oncology per se? Do you see any way forward through that, either through the programs you've talked about, and even maybe David through the peer learning stuff, a way to kind of get to that level? And that would help get us, I think, down the field much faster and farther, but I don't know if it's practical.
I'd be happy to share my thoughts on that. Thank you very much. I think that the reality is we do the best we can, and hopefully we move to a better place. I think we are already seeing significant consolidation in the marketplace, and I think we'll probably continue to see that. I think we'll see larger and larger groups, and and it's not only for purposes of aggregating expertise, but it's also for other economies of scale. And I think as we do that, then we will likely see that these large private practice groups will function in many ways more like an academic department. I think they'll probably be the places where you start to see these blended models. In fact, you already are starting to see that, although it's relatively informal. I think when that doesn't happen, I think we have to be careful again there are heavy coordination costs with high degrees of subspecialization. And I think that, yes, very much it is possible within a relatively small group that you have a person essentially, or a very small group of people that serve as the local experts, and they're the ones that then lead in that area. I mean, we look at the different subspecialization models that you could have. It could be modality-based or organ system-based. It's age-based in pediatrics. It's procedure-based in IR. It's urgency-based in emergency medicine. It's pathology-based in oncological imaging. I can't divide my department in that many ways anyway. So I think we need to have a model that you can have a leader of that area, and then they can learn and teach and provide feedback, and they all learn together. And it's also a much more positive environment to work in.
Thank you. Fiona, any comments?
Just back to your point about I think there's a big difference between academics and community, and even the training in academics and the training in community is different. So one example would be the Brigham and the Dana-Farber. The Brigham people still read the oncology cases, the same cases that we read, so depending on where the patient is scheduled in EPIC. So while some may feel like, oh, they're more cancer-based, those radiologists maybe shouldn't be reading them, the fact is that they're very used to reading them as well. And they do have the opportunities of learning available to them through our teaching program if they want to avail of that. So I think, not being a dedicated cancer imaging specialist in academics is different. You have the opportunities to keep up to date and to learn. In the community division, though, it's a little different, because I'm not sure those opportunities for learning are they may be available to them, but they're not as aware of them. So, for example, they may go to CME courses and that, but it doesn't necessarily keep them up to date with things, and so it's problematic. And I think that's why at the Brigham we ended up taking over a lot of the Foxborough cases. Anything that has any mention of cancer, they're sent to us.
Okay.
And so potentially, I guess you could champion a leader in those community divisions, but that person really needs to get dedicated education and know how to keep up with what's new and have a formal plan. They can't just be the assigned person, because they'll get lost, I think, pretty quickly without being able to keep up with the latest and the greatest.
Got it. Thank you. We have lots of folks in the microphone. Hetty.
No, I just want to echo what Fiona just said. I really like your idea of deputy, a specialist in oncologic imaging within a practice. But the big question is one, and that's what happens with our fellows. I'm sure with your fellows as well. They join the practice and they are the expert. So it really has to be organized. Training is extremely important. And then in cancer care, equally, if even not more, it's how to keep up. So it's not just fellowship, but then what do we, and that's why I know, Brent, I'm sorry, but I know that you don't want another certificate of qualifications, but why not? Cancer is so prevalent, it's crucial. I mean, you make a mistake and you miss a fracture, fine, so you'll have a deformity. You miss a cancer, you'll die. So it's a different scale. So why wouldn't we have somehow come up with a system? And what David said, Larson, it has to be organizational. It cannot be like the individuals or individual centers asking for it. So I think it's a great, we'll put this on the key points.
Great. Thank you.
Yes, Brian, sure. So there's been great advances in moving towards competency-based teaching. But it seems like we're still in a time-served-based training program. And I think that the two kind of most glaring examples I've seen are in anatomic and clinical pathology, where it's clear that you can achieve competency in either anatomic or clinical pathology with 2 years of training in either of them, but there's still 3 years of time served necessary for individual anatomic pathology training or clinical pathology training. And then also with foreign medical graduates, those who have done training in other countries and come to the United States and oftentimes have been practicing for many years and yet are still required to complete a full residency training as opposed to showing where they're competent and then potentially retraining where they need to improve the competency. So I wonder if the panel, I'm not sure about what radiology training does in those situations, but maybe, but it's still a years served model rather than a competencies achieved model for being able to sit for boards. And I'm wondering if that would be a dramatic change. I wonder if you could potentially discuss where we might be moving towards a competency-based system.
Ritu, you spoke about competencies.
So, yeah, thank you. I did mention briefly about the EPAs, the entrustable professional activities, and those are designed exactly to do what you say. People learn at different paces, whether it's medical school or residency fellowship, and what is being looked at, and we're about to start pilots and on this, and the American Board of Pathology, while we're not involved directly with the implementing the training, is supportive, because if a system like this worked, then we would have to figure out examinations at different points when people would when people learn differently, yes, they're capable, and then they should be entrusted, and the entrustment portion means that we entrust them to perform that activity, that professional activity, independently. So they've sort of graduated from that. They may not graduate in all of the EPAs at the same time. So it is a little complex. And, we've got pediatrics, as I said, the poster child ahead of us, who's taking a cohort through medical school, residency, and fellowship on this EPA sort of learning track versus the traditional. So I think we'll have lessons to learn from there. But 3 things that I mentioned that we're looking at in piloting in pathology are frozen section, autopsy, and interpretation of a clinical pathology test result. So the pilot hasn't taken off yet, but we do have plans to look into this. So it's on the way, but not developed to the point where it's going to change anything yet. It takes pilots to prove it and make sure that we're not, doing something that could not be successful and actually miss the point altogether.
Good. Kojo?
Yeah, I wanted to mention that in a rapidly exploding field, a rapidly evolving field like genomic pathology, which I practice, I think what has the best chance of eliminating the kinds of variability that we see ends up being building a focus around systems, less so than the individuals. I think, for example, 10 years ago, most of what people are excited about today with genomic sequencing and so on and so forth was not really in the clinical realm. So there are areas of understanding and sophistication that 10 years ago you wouldn't have been required to know. You'd have passed the boards, and they'll be required for your practice today. There are big fields that have opened. The whole area of genomic informatics didn't exist 10 years ago. And this is now a requirement. It requires dedicated time to develop expertise in that area in the first place. And beyond that, to be able to teach it effectively. Now, because of the high dimensionality of the data, it's now obvious to us that one center by itself might not even have enough in the way of cases or experiences to be able to figure out what the genomic diversity of normal looks like, okay? So what that means is that as a system, we have to figure out a way to integrate databases with different institutions and different agencies that make it possible for us to be able to share information just to understand what the variations in normal look like. That is totally different from the competence that you would require from an individual to interpret the data that comes from such an enterprise. So I think keeping in mind that there's a lot to be said for peer training and so on and so forth. I started 2 fellowship programs in 2 different institutions. I get that. I know the documentational process. You have to be fastidious and so on and so forth. But if you really want to make a difference at the level of the patient, which this is what this is about, we have to start looking at the problem as a systems-based problem, less so than individual-based.
Thank you. Dana?
Thank you for mentioning that particular key piece and bringing the patient back. I just want to reinforce again that I think that there are key opportunities in training and competencies and recertifications. And while we're trying to resolve those issues of perception and interpretation, I do know from my end, although again a smaller percent of our larger world and the successes we have, a significant portion of our failures in this area aren't even our interpretations. They're communicating that to our patients. They're getting the final result into the hands of providers and patients who can actually act on it. The number of cases that we see in our world that we had it right, we just didn't get it to the right people to act on it and make a final decision is as important to solving this problem as it is in teaching all of the new modalities and the extension of how we learn all of the new things that we need to learn. We've got to keep the system supporting the system and remembering to communicate and collaborate. I had the opportunity recently to be at Hershey in Pennsylvania to do a really interesting set of workshops with residents in the ED and radiology, simply teaching them how, in fact, to have communication, to have open communication between 2 services that often see themselves as very separate and very divided. And in fact, to present them at the very case level, use cases. It is so powerful to present cases so that we can understand how they unravel and fall apart and what role each of us plays in those individual cases. So while I applaud and support, and much of our work, grant work through CRICO, is focused on improving the skills, we do just as much work on improving the systems and communication and the collaboration with our patients. So thank you.
Good. Thank you, Dana. Ramin?
So one question for the panel, I think as we heard earlier from Hetty, if half the imaging in the United States is for cancer and 40% lifetime risk of cancer is a population level data we're looking at, are we really talking about a lack in our curriculum to develop content for cancer care for the people we have so that we can have a GU oncoradiology expert opinion, because an oncoradiologist cannot exist in a vacuum, because that oncoradiologist is not going to have the same credibility interpreting a neuro MR than a prostate MR. So is it that we're lacking a curriculum for cancer care, for imaging, and perhaps for pathology that is not being deployed, examined, and matured in a way to care for cancer patients, because to deal with half of the population, that is not going to happen with creating a new group of people who do this uniquely.
Brian.
Yeah, that's a great set of questions. And I don't think it's as much about curriculum. I want to refer back to what Jim said a few minutes ago. It's about scale and volume as much as anything else. And we saw the federal government do this 20 years ago with mammography, where there were radiologists out there who were reading 200 mammograms a year extremely badly. They couldn't help it. No matter what their knowledge and training was, the fact is, if you're only reading 200 a year, you weren't going to be good at it. And the federal government through MQSA said the new number is 480, which is still way too low for most of us in practice. And it really gets to, do you have enough of a given type of case to be comfortable with it so that you can differentiate normal from abnormal and have the knowledge base to then back it up, to Fiona's point? Do you know enough about the disease processes and the way it's treated and what to watch out for in terms of complication? And it really gets back to scale. And the problem, I think, is that we still see the world is not as flat as you'd like to think in this world. And you know, all this stuff, especially radiology, we've been moving image around for 2 decades. But the reality is most imaging is read very close to where it's performed. It's in the local community. So in a perfect world, you'd be having only, you know, we would only have 80 prostate MR readers, and they'd all be in a site. I would choose San Diego, actually, not Reading, Pennsylvania. And they'd be reading all the prostate MR for, you know, the state of California or for the western half of the country or whatever. And the reality is most radiology care is still provided reasonably locally. Even in Fiona's case, you're still reading cases for people who are within a 50-mile radius of where you are. So I think that's part of it. Is it's hard to achieve that scale when most of what we do is geographic. Does that answer your question? Because it was a very good set of points.
Yes, I think that's great. But the other point I was trying to make is, if we are hearing that our diplomats, the people who are graduating, do not have the expertise, the basic knowledge around cancer care, what can be embellished in our current curriculum so that our diplomats are at least capable of doing some level beyond where we are today? I think that's what we are hearing earlier.
Right, and that's that subspecialty piece Fiona was talking about and most abdominal imaging fellowships at least address that halfway. I don't think they do it quite to the degree that Memorial Sloan Kettering does or that Dana-Farber does, but that you're absolutely right. I mean, there are still probably shortcomings that are intended to be addressed at the fellowship level.
Yes, sir.
Yeah, Larry Schulman from the University of Pennsylvania. Fiona, that was a terrific description of a very thoughtful and detailed program. One of the points that you made, which I want to come back to, is the sort of holistic reading of a patient's exam or exams, which in my own experience doesn't occur in a lot of places. So, you know, you don't break it up. You know, you have one group reading the chest, another the abdomen, a third one the bone scan, and so on. And everybody's operating with only part of the puzzle. And it's sort of inconceivable to me, and I grew up in your program, so I believe that, but it's inconceivable to me that you can't do a better job if you're looking at all the data than if you're only looking at part of the pie. And the question is, should that be a standard for reading cancer imaging? You know, where you look at all the imaging that was done in that patient and use all the information, and you could make the same case about pathology as well, making sure that all the data from the different labs, the genome sequencing lab and the FISH lab and the IHC lab, all that's coming together for a unified interpretation, and nobody's reading just part of it. Can we get to that? I mean, that seems like something that we could do, without, advancing AI or advancing some of the other things that are more difficult.
Thanks,
I can't hold off any longer. A long time ago, a group of us decided as pathologists that it was important to start to create something called an information therapy report. Essentially a report that just got us pathologists together over our molecular, immunohistochemical, our anatomic, our flow cytometry reports, and put out an integrated report. And there is one part of medicine that does pathology that does this already. It's Heme Path, that's leading the way in the delivery of personalized care for cancer. Radiology's got the same problems pathology has had. We're our own enemy. We're so subspecialized that we never think back to putting together a nuclear report for the patient, in which the context of all of our complex and almost diarrhea-like amounts of paper that flow out of our laboratories are not put into something that's formed and solid for the patient's disease. We could talk a lot about wanting to take and improve the delivery of care, but really the enemy is us. And as we continue to subspecialize, fragment just the slice I know, and never take it back to the context of the patient, we got problems, and it's us.
So can I tell you, go back to money? Larry, I have to answer your question. We issued integrated reports. So of the last 3 weeks, whatever study you have, the report, you have to put an radiology only, integrated reports. Our RVUs of productivity is more than 40% less than across the street university where they don't do that. So, and I'm sure, Fiona, your RVUs, your group's RVUs are probably not really the best. We know because the RVUs for radiology practices are published every year. We are nowhere. People wonder how we can survive. So unless we somehow get, and integrated reports, we tried to do a clinic consultation, it didn't work with CMS. They will not recognize that as a billing part. So unless we solve the billing portion, you cannot expect that somebody in a private practice or community where there is no hospital to support you with or philanthropy or whatever, that can really practice that way. And I would love to hear from the community people, but it's not, they can't afford doing that.
And as Fiona said, there is a fair amount of subsidy for the radiology department for the way the services are provided at Dana-Farber, and I'm sure at Memorial Sloan Kettering.
Absolutely, at Memorial, yes.
As well. I just happen to know the details.
So you're talking about so we have the consultation services are subsidized by the Dana-Farber. So for each floor, there's one FTE.
Right.
And you do get the conglomerate report, but it's all verbal. That's the problem, right? So when we're reviewing the cases in consult, we're looking at any of the outside imaging, the CT, the bone scan, whatever the patient has done to come up with a finite plan with, sitting with the oncologist, but it's not a formal report, it's all verbal. And that in itself has issues because we recently realized that depending on the oncologist and how much of a hurry they're in, if they're asking you to look at something quickly, you're not exactly closing. A lot of times we don't close the loop, and we're not exactly sure what the message they're gone off with. And we've had a couple of occasions where the oncologist will put in their notes, I reviewed the bone scan with I reviewed the MRI with Dr. Fennessy, when in fact it was a CT scan I reviewed with them. And so, but there's so we actually have asked the oncologists, because we do a summary for them, but that they don't name us, that they say it was reviewed with radiology, because we don't know what they're putting in the report, and they don't have anything, to formal. So it's tricky.
So last word on this topic, Ramin.
I just wanted to clarify because we're coming from the same practice at Larry and worked with Larry for a long time. The way this works, and I think for the audience to appreciate, is that payments for radiology services are attached to an examination that's performed. What we're talking about is consultation at a patient level. When you're trying to coalesce all the information together, there is no way for radiologists to get paid for that service today. So in places like Dana-Farber or Memorial Sloan Kettering, the institution funds the Department of Radiology to resource these multidisciplinary cancer clinics with an embedded specialist or subspecialist to take care of the patient. So at the end of the day, the funds flow becomes a challenge for delivering the patient-centeredness that we are all talking about. So just a clarification.
But as we talk about quality and where the gaps are, do we need to come up with a different system with the payers? Because if this provides better care, should that be the stumbling block?
Yeah, there is a lesson. There were some colleagues here from CMMS in this from the cytology history in pathology when we had cytology mills. Essentially, CMS decided just fractionally, I think it was less than 0.5% of increased repayment was paid to pathologists if they subscribed to a standard of cytology reporting and quality. And overnight, in a matter of 2 years, every pathology practice and cytology lab across the country went to that reporting standard because they were getting 0.5 cent more on the dollar. Very little, because both pathology and radiology run on such razor-thin margins from the practice side, CMMS can do very little things to essentially incentivize appropriate practices here. But, unfortunately, over the last decade or more, CMMS has looked at pathology as a non-quality center and unessential to the practice of medicine, and particularly oncology. And there has not been any change in reimbursement for a long time. Maybe we need to refocus how we are financing through HHS and CMMS the way we value this for oncology, because it is the predominant thing we do in both radiology and pathology, and maybe do it in partnership between our disciplines to put some of those quality metrics in order and get back to patient-centered reporting.
Good, thank you. Anyone wish to respond to that? David?
I will say, as much as I would love that we had a policy change and that CMS did make this change, and I hope they do, I strongly support that, it may be a long haul to get there. I think some other ways that we may see this start to evolve are that you may see contracts basically with whatever payers may say, if you don't provide this level of service, we're either not going to provide the contract, or they'll use that as a basis for their contract, or they might provide an incentive internally, again, through the entire organization. That's where, again, I really think the solution is going to be, instead of it, necessarily piecework and individual focused, moving towards a whole organization working cohesively together to meet the needs of the patients and the referring providers.
Great, thank you. Yes, sir.
While you're on the CMS topic, I don't know if Ron, if you want to go ahead and make your comment.
Sure. Thanks, Rich. I'm Ron Klein. I'm a medical officer at CMMI, and I'm the medical officer that's the clinician involved in the oncology care model. So in terms of you're talking about how you pay for things differently, I will spare you the long detail, but oncology care model is about 190 practices, about 150,000 unique beneficiaries per year, about 20 to 25% of all the Medicare fee-for-service oncology in the country. And that is, I don't want to call it a bundled payment model, but it is sort of a hybrid fee-for-service to bundled payment type of transition model. So I would suggest to you, everybody's talked about breaking down silos, and you talk about breaking down silos in pathology, and you talk about breaking down silos in radiology. And I would suggest to you that you talk about breaking down all of those silos and thinking about an oncology care, think about oncology care for the patient, whether it includes medical oncology, radiation oncology, pathology, or diagnostic imaging. And then a total cost of care model, you may find that rather than doing things for certain reasons because CMS pays for things in certain ways, you may find that there's additional value to be had by having a radiologist attend in clinic as part of a multidisciplinary clinic, or share reports because you get better value, more efficiency, you do fewer scans, and you may find that that's sort of the path forward. And I'll talk about that more tomorrow.
Great, thank you. So thank you for seeing the last word. 2 more minutes, please.
All right, so Rich Shielski from ASCO. I know we're getting short on time. I just wanted to come back to this question of scalability for a minute, and maybe different people define it differently. The more we discuss it, the less I'm convinced actually that it's either feasible or necessary. You know, I mean, it's just not going to be possible to take the kind of radiology and pathology training and practice that exists at the Farber and Memorial and, you know, the big freestanding cancer centers and put that out in the community. I'm also not convinced that it's necessary because, you know, the case mix is very different. If you work at a big cancer center, you have 100% prevalence of cancer in your practice, and that's not the case in, you know, most of the community hospitals around the country. So I guess what I wonder about, and it would be great to hear the panel reflect on, it gets back a little bit to the question about core competencies, is what is the necessary core competency for a radiologist or a pathologist working in sort of a community setting to have with respect to cancer in order to best meet the needs of the patient population they're serving. And if the need that they have exceeds their core competency, then where do they get the expertise that they need to have at that particular moment?
Anyone wish to take?
So the only point I would add to that, I think when you're talking about relatively small or even large practices, it's not just the competency of the individual, but it's sort of the competency of the group. And you need to have practices in place which ensure that, to make sure you have the peer review and those kinds of activities. So it really invokes, as it were, a systems approach about how you do things.
I would say, because I'll just wrap up, that I think this is very much I'm sure what the ABR and the ABP spend a lot of time thinking about is what is the core competency that's needed out across the whole country. And I know there's a whole host of minds that go into that probably on a daily basis. So with that, I think we're out of time and time for lunch. So please join me in thanking our panel. They did a terrific job. And I think we reconvene at 1:30. Thank you.